with degludec and aspart.
Thank you, Dr. Irfan, for the introduction. Bismillah ar-Rahman ar-Rahim, Assalamu alaikum, and very good morning to all who are present in this hall. As Dr. Irfan introduced me, but I will do a bit correction in the topic. Actually, my topic is about the management strategies of hypertension in diabetes. So it is not like that. I think we have missed that topic. So without delay, I will start with my presentation. Rather, before presentation, I will like to grab the opportunity of thanking the organizers of this conference for inviting us, particularly Dr. Ahmed Shehzad, who was very keen that there should be a participation from Balochistan. So we came with a delegation of about 20 people who are participating in this conference. So thank you, Ahmed Shehzad sir, for inviting us and making us part of this presentation. As I told you that my topic is the prevention and management strategies for hypertension in diabetes. This is the place from where I come. May I know from the audience that, with a raise of hand, that who has visited Quetta city? Very less number. So for those who have not visited, I am telling them that they are missing something very important in their life. Please do visit Quetta, a beautiful city. Thank you. Before I embark onto the main topic, that is the formal presentation, I would like to share with you a figure which is taken from the ADA Standard of Care Guidelines in Diabetes. One of my colleagues has already shown this picture to you, but luckily it talked about the fourth pillar, that is the agents with cardiovascular and kidney benefits. So I'm left with the three pillars. If you look at these pillars, they make up the metabolic syndrome actually. So metabolic syndrome includes the glycemic management, that is hyperglycemia, blood pressure, and the dyslipidemia. So what these three pillars, that is the metabolic syndrome, do hazard is in the form of the ASCVD, that is atherosclerotic cardiovascular disease, which includes three conditions like coronary artery disease, cerebrovascular disease, and the peripheral arterial disease. The magnitude of the problem, you can imagine that the magnitude of the problem in USA for correction of the ASCVD related complication is about 39.4 billion a year. So this is in the dollars. And let me tell you that the health budget of the USA is $12,500 per person per capita per year. Anyone knowing that what is our budget of Pakistan health budget per capita? It is $38, just $38. We are just above, I think, one of the African countries, Tanzania, which is lower than us, and we have the minimum amount of budget for the healthcare. So by saying that, I mean is that treatment is not an option for us. They can afford to have correction of the ASCVD related conditions. They can go for PCI, which costs about in lakhs, in thousands of dollars. They can afford to have mechanical thrombectomy. They can have the peripheral stents, but our resource limited country cannot afford this. So what we are left with is the option of preventing this condition. So as I told you that the metabolic syndrome includes three of these things: dyslipidemia, hypertension, and the glycemic management. I'll be talking about the blood pressure management in particular this time. So the objectives of my today's talk will be screening and diagnosis of the hypertension, measurement of the blood pressure, white coat and masked hypertension differentiation, prevalence of the hypertension in diabetes, pathogenesis of hypertension in diabetes mellitus, and non-pharmacological treatment of hypertension, and then I will go on to the pharmacological treatment of the hypertension. First thing is the screening and diagnosis of hypertension. That is of pivotal importance in patients with diabetes, that we should diagnose hypertension timely and manage it accordingly. So blood pressure should be monitored on every visit of a diabetic patient when it comes to your clinic. So you should screen for the blood pressure of that patient. Then is the hypertension is defined as a systolic blood pressure of more than or equal to 130 mm of Hg, or a diastolic blood pressure of more than or equal to 80 mm of Hg. This should be confirmed on 2 or more occasions. So if the patient is in hurry, what your strategies can be that you do check the blood pressure, and if it is above, what you expect is that after 1 minute you will take another reading. So if there is difference between the 2 readings, then it is better to take a 3rd reading. So then after that you can take the average of the last 2 readings, and that will give you the exact blood pressure of the patient. So that is for one setting. Individuals with a blood pressure of more than 180 by 110 and cardiovascular disease could be diagnosed as hypertension at a single visit. So in that patient you will not be able to delay the management, so you can immediately start the management to those patients who have a high blood pressure like 180 by 110. So another important point is the measurement of the blood pressure. Correct technique of the measurement of the blood pressure must be applied by a trained individual with a BP apparatus which is validated. Sometimes the blood pressure operators, they are by themselves defective, so they will give you the wrong reading. I will float another question at this moment. Anybody knows that for the first time in the history, the blood pressure was measured? Any idea? Okay, let me tell you. It was by Stephen Hall in 1708. He was a clergyman and not a physician by profession. So that was the first time, and he did it in a mare by introducing a catheter into the arteries of a horse, and he measured the blood pressure. So when did it come into practice that the blood pressure measurement became a routine in examination of patient is about in 1905, and it was by the Kotakov and Janeway. So 200 afters, it became a routine part of the examination. So how do you check the blood pressure? The prerequisite which you should take while measurement of the blood pressure is done, patient is rested for 5 minutes on a chair with a back support. Patient must not have smoked or consumed caffeine in the last 30 minutes. The feet of the patient should be touching the ground, and they should be uncrossed. Arms supported at a heart level. Appropriate size cuff should be used. It should not be large, it should not be small. Examiner and patient should not talk during the measurement, and look for the postural changes in BP and pulse too. So you should look for the postural drop as well. So it is also recommended in NICE guidelines that you should not make the patient wait to come to you for too long, and that will make the patient angry and may affect the blood pressure reading. So all these precautions should be taken before measurement of the blood pressure. If you by any means suspect that patient is having a white coat and masked hypertension, so white coat or masked hypertension is suspected, home blood pressure self-monitoring or 24-hour ambulatory blood pressure monitoring may provide the evidence of correct blood pressure in those patients. As far as the prevalence of hypertension in diabetes is concerned, I will tell you that solely hypertension is present about in 1.2 billion of the population. That makes about 32 to 34% of the world's population. On the other hand, diabetes prevalence in the world is 537 million individuals, which makes about 10.5% of the world's population. So out of these, those patients who are having simultaneous diabetes and blood pressure, it varies from 40 to 80% depending on few factors, which includes the duration of diabetes, age, sex, race, ethnicity, BMI of the patient, history of glycemic control, and the presence of kidney disease. So whenever the patient is having both these conditions simultaneously, that will be called that the patient is victim for deadly duo. So the pathogenesis of hypertension in patients with diabetes, there is a very famous theory which is called common soil theory. In that theory suggests that a patient who is prone to develop diabetes has the potential to become hypertensive as well for the factors which are seen in this diagram, that the matter starts from the genetic predisposition. So the first thing is that the patient is genetically predisposed to diabetes, and because of that, when it is combined with the environmental factor, which may be in the form of bad eating habits, junk food, high carbohydrate diets, that will lead to the visceral obesity, that will ultimately lead to the insulin resistance, and insulin resistance is going to cause all the mess. It will cause the diabetes, obviously, it will lead to the hyperglycemia, but along with that, because of the insulin resistance, there is increased inflammatory markers in the form of CRP, TNF, interleukin 6, which will lead to the premature aging, that is going to lead to the increased vascular resistance. And this is one of the factors of the hypertension. Along with that, there is endothelial dysfunction, increased VCAM, vascular cell adhesion molecule is increased, and nitrous oxide is decreased. Insulin resistance also causes sympathetic nervous system stimulation, which will lead to the peripheral resistance and increase in the blood pressure. And along with that, there is RAAS activation, renin-angiotensin-aldosterone system is activated, which, as you know, will lead to the hypertension. And ANP suppression is also there. So there are many factors which is going to lead to the hypertension in patient with diabetes, but they are the basis of all this is in the insulin resistance. So insulin resistance will cause diabetes as well as make the patient prone to become hypertensive as well. What is the evidence for benefit of the treatment? This will be shown by, I will share with you few studies which are given in the ADA guidelines. One is the hypertension optimal treatment, in which there was 18,790 patients studied. Out of these, 1,501 were diabetic. So they were divided into two groups with intensive blood pressure control and the standard blood control. In diabetes, an intensive diastolic target was associated with significantly reduced cardiovascular events up to 51%. So that is a significant number. Another is the advanced BP. 11,140 participants were there in this study, in which the intensive blood pressure was 136 by 73, while the standard blood pressure was 141.6 by 75.2. So reduced risk of major macrovascular and microvascular events up to 9%, death from any cause was 14%, and death from cardiovascular disease was 18%. So this study again favors the good control of blood pressure, has got benefits. And there is another study which is Accord BP, in which there were 4,733 participants with type 2 diabetes mellitus. Their age was from 40 to 79 years with prior evidence of cardiovascular or multiple cardiovascular risk factors. The outcome of this study was that no benefit in major adverse cardiac events, but stroke risk was reduced by 41% with intensive control. Sprint study, this was without diabetes, but it was only for the hypertension. It shows that low risk of the primary composite outcome 25%, reduced risk of death 27%, and increased risk of electrolyte abnormalities and acute kidney injury. So it has shown the adverse effect of the antihypertensive drugs as well. What is the evidence for the blood pressure targets? What should be the target of blood pressure in patients with diabetes? So ADA position statement is that most patients with diabetes mellitus and hypertension should be treated to a blood pressure less than 140 by 90 mm of Hg. For individuals at high risk of cardiovascular disease, if they can be achieved without undue treatment burden. So you should keep in mind the pill bill burden of the patient. So if the patient is having other risks for the cardiovascular disease, it is better to reduce the blood pressure for less than 130 and 80 mm of Hg. How do we control the blood pressure in these patients? So we have two kinds of strategies for patients. One is the non-pharmacological and the other is the pharmacological. So best proven non-pharmacological interventions for prevention and treatment of the hypertension. It includes a few of the lifestyle modification. First, which have already been discussed by the Javed Akram Saab, that weight reduction is the essential part of management of diabetes, but it also benefits the patient in controlling the blood pressure of the patient as well. So ideal body weight is best goal, but at least 1 kg reduction in body weight for most of the adults who are overweight, expect about 1 mm of Hg. So 1 kg, 1 mm of Hg. So if you reduce 10 kg, you will have a reduction of about 10 mm of Hg reduction in the blood pressure. On the other hand, if the patient is obese but not having hypertension, if that patient reduces his weight, so it will not affect the blood pressure too much. So this is particularly for those patients who are having obesity plus they are having hypertension, so it will have beneficial effects. Healthy diet in the form of DASH, dietary approach to the to stop hypertension, Mediterranean diets, so different kinds of diets are there which can reduce the blood pressure. So dietitian fruits, vegetables, whole grains and low-fat dairy products with reduced content of saturated and trans fat can benefit the patient and may reduce the blood pressure up to 11 mm of Hg. Reduced intake of dietary sodium. So dietary sodium should be cut off and it should be reduced to less than 1,500 milligram per day. That is optimal, but at least 1,000 milligrams should be cut down per day. That is going to benefit the patient up to 5 mm of Hg in reduction of the blood pressure. Enhance intake of dietary potassium. So on one hand, if you reduce the sodium intake, on the other hand, if you increase the potassium intake, so that is going to benefit the patient. Again, reducing the blood pressure by 5 mm of Hg. Physical activity is very important, as was discussed by the Professor Dr. Aftab Mohsin, that about 90 to 150 minutes per week, 90 minutes of intensive exercise and 150 minutes per week of regular exercise is essential for patients with diabetes, and that is going to reduce the blood pressure as well. The exercise may be in the form of dynamic resistance, which is like bodybuilding and doing it with the dumbbells, and it may be isometric resistance, doing some planks or supporting your body with body weight with your arms, or push-ups or pull-ups like that. So whatever you like, whatever you feel comfortable, you should introduce exercise to your daily life. Moderation in alcohol intake is again important, so that should be reduced. So another point which I will add is the cessation of smoking is also very important in daily life modification to reduce the blood pressure. So all these things are non-pharmacological modalities which can reduce your blood pressure by changing your lifestyle. This is a bit busy style. It is again taken from the ADA standard of care guidelines, which shows the pharmacological treatment of hypertension in patients with diabetes. Actually, the population of diabetes is divided into two groups. One having a blood pressure of 140 to 160 mm of Hg, so that group is on one side, and the other is a blood pressure more than 160 systolic. So you start with introduction of the lifestyle modification in both the groups. While the group with a blood pressure up to 160, you start with one drug. You assess the patient and look for the coronary artery disease. If the patient is having a coexisting coronary artery disease, those who are having coronary artery disease, it will be wise to start with ACE inhibitors or ARBs, while if the patient is not having any other risk, so you can choose any of these three groups, that calcium channel blocker, ACE inhibitors, ARBs, or diuretics. On the other hand, those patients who are having a blood pressure more than 160, look for the albuminuria or coronary artery disease. So you will better to start with two drugs. Those patients who are having a blood pressure more than 160, it is better to start with two drugs. So the group who is having albuminuria, you will start from, without albuminuria, you can start from out of these three, that ACE inhibitors or ARBs, calcium channel blocker or diuretics. You can start any of the two drugs. While on the group which is having albuminuria or coronary artery disease, you need to include ACE inhibitors or ARBs, plus you can add either diuretic or calcium channel blocker to lower the blood pressure. So you will reassess the patient. Reassessment of the patient is very important. If the blood pressure is controlled, okay, you will go with the same strategy. Or if the blood pressure is not controlled, so you will again go and change the molecules. Either you will go for the maximum dose or you will change the combination of molecules. Even if that is not successful, obviously it will go into the classification of the resistant hypertension. So at that time you will need an expert. Now, who is the expert to deal with the hypertension is the hypertension specialist. Who can be the hypertension specialist? A nephrologist, endocrinologist, or a cardiologist. So debate is there, but American Heart Association says that a person who is having fellowship in hypertension, he is labeled as hypertension specialist. So fellowship of hypertension takes about 3 years course, and the eligible person for getting the fellowship is either with a background of endocrinology, cardiology, or nephrology. So these can apply for the fellowship in hypertension. So hypertension by itself, a very complicated thing, because it has got neurohormonal control. So to deal with the thing which has got neurohormonal control, it is always very complicated. American Diabetes Association recommends that patients with diabetes and hypertension blood pressure targets should be individualized through a shared decision-making process that addresses cardiovascular risk, adverse effect of antihypertensive medication, and the patient's preferences. So you will involve your patient in the management goal. So with the agreement of the patient, you will start the therapy.